What's up, guys? Welcome to another episode of the Medicopolis podcast, where two teenagers discuss medical dilemmas and police them to reach an ultimatum on whether the situation is ethical or not. Thank you so much for taking the time out of your day to listen, and we hope you enjoy our episode on the ethics of medical malpractice.
So, what is medical malpractice? Medical malpractice is when a doctor or other medical professionals treat an injury by a patient by providing inattentive medical care and making an error regarding surgery, treatment, or misdiagnosis. Essentially, it's when the doctor doesn't provide their full care to a patient by either misdiagnosing or just not noticing something or not taking the proper precautions on something that the patient could have. There are many types of medical malpractice, but the two main ones are misdiagnosis, like I already said, and practitioner error. Practitioner error is a preventable error that occurs during any sort of procedure or during a consultation that has a negative impact on the patient's well being.
Some types of practitioner errors include incompetence, where the practitioner might not have the skills or experience necessary to complete the treatment successfully, poor communication, where the practitioner must have proper and direct communication with the nurses and assistants throughout the entire treatment to ensure proper dosage of medicine is given to the patient, and the failure to give these requirements would go under poor communication. Next, there's improper work process, where practitioners determine that some steps for planning treatment or during the process are unnecessary, and failure to take the proper steps and follow the correct procedures when performing treatment falls under this cause. Another type of practitioner error is insufficient preoperative planning, where it is critical that the practitioner is well prepared for treatment, where this can include planning and reviewing process for any complications that could potentially occur with the patient during the process. And it also could include proper preparation by nurses and assistants to ensure that all the necessary equipment is ready and available when needed by a physician during any point of time during the treatment.
Another type of practitioner error is fatigue. This is actually quite common, as doctors are known for working notoriously long shifts. This results in fatigue. People are more likely to make mistakes on patients when delivering treatments compared to the well rested people. Another type, which is actually one of the more common types, is neglect. Sometimes doctors just simply are not as careful as they should be. This could include failing to ensure their instruments are properly sterilized, the decision to use equipment known to be defective, or sometimes the doctor is simply just not providing full care for a patient because of outside emotional reasons. There are many reasons that can fall under neglect, which is why it can be one of the more complicated parts of a lawsuit or a complaint. The last, well not least, form of practitioner error is drugs or alcohol. Some doctors actually resort to using drugs to cope with stress. Sometimes the doctor will even be under the influence of drugs and alcohol. It falls under the serious offense of not being in full control while treating a patient. A rare occurrence, but it does still happen. And while these are not the only things that can happen to a practitioner that could cause a lawsuit, these are the main important parts, and the rest of the situations typically fall in a gray area of a mixing of some of these things, like fatigue or neglect, or a mix of both. So that all just depends on the specific scenario. So it's up to the patient in order to deliver that info to whatever lawsuit is trying to be declared, I guess.
So now that we've mentioned the types of medical malpractice, you may be wondering on how one could go about a medical malpractice claim. And to answer your question, to bring a successful medical malpractice claim, an individual must establish that there was a doctor patient relationship, that the doctor provided insufficient care, that the doctor's negligent care caused the patient's injury, and that the injury caused significant harm to the patient. If any of these elements of proof are missing, then unfortunately the claim cannot be successful. Medical malpractice lawsuits are complex, and therefore, individuals who are hurt by medical malpractice by a doctor or hospital tend to pursue a lawyer to help them with their efforts. Now, I know I mentioned that there were four elements, and I want to go a little bit deeper into them. The first one being duty, where the doctor typically has to be in care for the patient, so they have the duty to act as a reasonably competent doctor. Next element, breach. Did the doctor breach their duty? A doctor won't always misdiagnose because of harmful intentions. In order to determine that they breached their duty, the patient or client has to determine whether precautions were taken in case of a different diagnosis or if another reasonably competent doctor could have diagnosed it properly.
The next one is causation, which is basically if the doctor's misdiagnosis actually caused the patient harm. So, for example, the doctor may have misdiagnosed someone with with cancer instead of the flu, but the next day someone ran them over, killing them. Does the doctor's misdiagnosis actually cause the death? No, it isn't. Just because the person had the cancer instead of the flu doesn't mean that the car accident would have not been there essentially had that happened. So that's not on the doctor. And then the last one is damages, which is if the misdiagnosis actually caused damage. The doctor may have misdiagnosed a patient with migraines instead of the flu. However, the prescription was Tylenol, which actually cured the flu as well. This means that you didn't suffer any damages because of the misdiagnosis, and technically wouldn't have a case. Because the doctor's misdiagnosis didn't actually cause any harm, besides maybe a few extra dollars.
Then there's ethics violations, which can sometimes be considered medical malpractice. In general, ethics violations aren't necessarily considered grounds for medical malpractice. They're considered outside the scope of the law. And some ethics violations may dramatically affect a patient's level of care. For example, improperly prescribing medication because a doctor is being paid to promote it may be considered medical malpractice. And failing to obtain informed consent about a medical procedure before beginning it may also be considered medical malpractice.
When a doctor is diagnosing a patient, there are a couple steps that the doctor must follow. Typically, the doctor has to receive all the information directly from the patient, which means there could be some bias in that procedure already. And then it's up to the doctor, based on the information they receive, to come up with a list of possible candidates for whatever the problem could be. And then it's up to the doctor themselves to try to figure out how that would what is what, which could be either by running tests or by asking the patient more questions or by doing like a biopsy, things like that. So basically, from what a patient can do, automatically there are places where there could be medical malpractice because say the doctor thinks, "Oh, this is the flu" or something, like a very cut straight case, then there could be medical malpractice there because the doctor already isn't considering all of the options. Just because they have sniffles and a cough, especially in this day and age of COVID, it could be something much greater, something much worse. So that has to be taken into consideration whenever the doctor is dealing with a patient. So in that kind of case, the doctor would have to run tests, probably just like a COVID test, to see if it is COVID, because they have to rule out all the possible options before they move on to their next diagnosis, or stating the diagnosis, or giving treatment randomly, or sending the patient home when it could actually be very serious and lead to something really bad. We'll get into a few cases that sort of deal with this kind of problem, where the doctor can sort of write off a problem as something simple, send the patient home, and then end up leading to catastrophic stuff. So basically, what I'm trying to get across is that medical malpractice is not something that is very cutthroat. You can't look at a case and say, this is medical malpractice, without any sort of background or by taking into great consideration the details. You have to first understand the whole process and get all details in order to understand, was this neglect? Was this substance abuse? Was this like from the doctor or something that caused the doctor to have an incorrect diagnosis? Was this any sort of other reason? That all has to be taken into consideration. So these cases can get into extreme situations where almost all details have to be revealed, which, if you remember from our confidential care episode, is something that cannot always happen. So sometimes the decisions are being made by other people.
Another thing we wanted to bring up is informed consent. Informed consent plays a big role in this medical malpractice process. Essentially, the healthcare provider can't just go ahead and ask for consent to treat a patient upon admission to the area of treatment. They have to give context. Why? It's their ethical obligation to disclose the nature of the procedure or treatment and essentially what it'll entail. However, this idea of informed consent isn't always necessary in specific cases of emergency care. as well as if a doctor or parent or guardian isn't always available. They can only bring a malpractice claim only if the doctor didn't fulfill their ethical duty with informed consent. Informed consent would generally go under the duty element of a malpractice claim, which we brought up earlier, and it generally plays a significant role in the outcome of the claim. Now, Ashwin and I want to transition to some of the cases of medical malpractice and kind of go over them and give our opinions. First one, a 53-year-old male presented to the hospital with a complaint or multiple complaints of acute chest, epigastric, and back pain with nausea. No pain radiated to the arm or jaw. He gave a history of hypertension, diabetes, and being a smoker. One of his brothers had died from a heart attack. The day after admission, the patient complained of epigastric pain in his lower chest, which is usually the result of overeating, drinking alcohol while eating, or consuming greasy or spicy foods. The following day, however, the pain had disappeared. There was chest pain only when touching the chest, so the internist, or doctor that specializes in internal body medicine, believed that it was not originally a cardiac problem. Eventually, he was discharged with instructions to follow up with the internist in 2 to 3 days, but the patient did not schedule an appointment. 2 weeks later, he came back to the emergency room with complaints of chest pain, and the electrocardiogram, or EKG, confirmed that he had experienced a heart attack. There were problems with the arteries, so was done, and eventually it turned out successful. A medical malpractice claim was filed, alleging that the internist had failed to diagnose and treat an impending heart attack. And many reviewers of the case said that even though the numbers weren't completely there and that the pain was abnormal, the internist should have seen a potential problem and should have prompted screenings and diagnostics that could detect heart diseases. So, Ashwin, what do you think both parties could have done better? I know that the reviewers kind of gave their opinion, but I want to know a little bit more about your opinion.
So I feel like the patient, the critical mistake that he made here obviously is not following up with the internist in 2 to 3 days. But I think that besides that, he did give a lot of info and a background, and the fact that one of his brothers had actually died from a heart attack or an MI. So I think that it's very important to note this. He did bring up the fact that this could have been a factor to his pain. And interestingly enough, the epigastric pain that people can experience sometimes is because of clogging of the arteries or sometimes just heart constrictions, which can lead to an MI or heart attack. So the fact that the internist didn't actually catch this, but I was able to Google this and figure that out, is something that I think should be on the internist here because they realized, or maybe they didn't realize, but they knew that he had epigastric pain, and with a history of heart attacks, it also increases the risk, essentially, if that makes sense. So he knew that the epigastric pain could have led to a heart attack because of a background, but instead of following up, especially I guess because of his background, they didn't even bother to try doing anything about it, which I feel like is on the doctor. But I don't feel like this would be like neglect or just improper or poor communication. I feel like this is just incompetence because for something as simple as epigastric pain, which with a background of heart attacks could be a necessary risk that you need to, I guess, sort of watch out for, I feel like the doctor, since the doctor didn't, that's on him. He should have realized that. So I don't know. That's what I think. Any thoughts?
Okay, and then like just a quick follow-up question. Do you think the doctor was ethically incorrect? Because I know we've talked about previous episodes where the doctor is supposed to kind of follow through the entire process and they failed to do that. Do you think that they're like morally incorrect here?
Okay. Well, this depends because the patient did not make a follow up. So all things considered, I guess I personally would say that I don't know because ethically speaking, the doctor didn't want to, I guess, go against that confidentiality by pushing an appointment with the patient. So I guess in that way he did something right. But by doing that, he also unintentionally made a mistake because he could see the risk factors of an MI or a heart attack, and instead of trying to contact the patient, he instead waited for another instance with the patient, which actually ended up being too late because that was when there was an MI or a heart attack. So I feel like this specific case is interesting because he did the correct thing while also doing the incorrect thing. It just depended on if the doctor realized that epigastric pain plus a history of a heart attack could lead to a problem like this. Moving on to our next case about a 42-year-old female non-smoker presenting herself to an internist for a cough that was unresponsive to antibiotics or albuterol treatments. The internist sent a letter to the patient advising her to make an appointment for a CT scan to determine the root of the problem, but the patient did not return to the physician, and the physician made no attempts to communicate with her. That's important. She saw another internist, sorry, but her medical records and chest x ray report were never sent to the new physician. 18 months later, she was diagnosed with stage 3 lung cancer. So the two physician and the internist were never actually conjoined in their data. So the conclusion of I guess, early stage of lung cancer was never found because of this. So, Saj, what do you think about this case? Because there are problems on both sides here. So, whose fault do you think this is?
Yeah, I mean, like, this is really just a clear example of poor communication through all parties, right? Because when there's a condition as serious as this, the physician and patient should really never lose contact, and they should end on terms where they understand what's going on. And also that transition to the new physician, that kind of bugs me as well because the other previous information that is necessary for that new physician wasn't sent over. I think there were a lot of ethical mistakes made here from all parties again, specifically in this communication aspect. I think that the old physician should have reached out to that patient that they had with problems and they should have figured out what's going on. However, do I think this is a medical malpractice case? I wouldn't necessarily say so. I don't think there were any of those clear four factors present here. So I actually don't think that this is a case. This could be made a case.
I like how you bring up the four elements because I think this directly sort of conflicts with the first element, which is, again, duty. So, with duty, the doctor has to be in care for the patient, so they have to act as a reasonably competent doctor. But in the case where the doctor doesn't know how serious the condition is, where it's just a cough that wasn't treatable, in that case, the doctor should have noticed maybe something that was going on, but in that kind of early stage, you can't catch that kind of problem. And when the doctor tried to get a better diagnosis by trying to do their own research by asking for tests to be run on the patient didn't respond. So in this case, the patient has no case here because the duty was never to catch lung cancer, it was just to treat a cough. And then the doctor didn't breach their duty because they never got to their duty in the first place because the patient actually just ended up not responding and trying to go to a different internist. So this isn't a fault on the doctor, in my opinion.
But I still do want to bring attention back to that I think there could have been better actions taken here. I don't, like we both said, this isn't a medical malpractice claim by any means, but I think that there could have been a few things done better from an ethical standpoint in this scenario.
Yeah, just morally speaking, as this isn't a medical malpractice case, this is just a case of human ethics. This case also has to do with human ethics rather than a medical malpractice case. A 20-year-old morbidly obese male arrives at the ER with difficult breathing and lethargy. He had a recent history of strep throat and was taking antibiotics. Upon admission, his blood pressure was 155 over 97, heart rate of 145, and blood glucose of 450 milligrams to DL. He was started on insulin and admitted to the ICU with a diagnosis of diabetic ketoacidosis, which is a lethal form of diabetes. Shortly thereafter, the patient became comatose. A brain CT scan, blood cultures, and neurology consult were ordered. The impression was probable sepsis, which is an extreme infection response that can damage the organs and the liver, and diabetic ketoacidosis, while meningitis, which is the swelling of the outer brain and spine membranes, were ruled out. A lumbar or lower spine puncture, or also known as LP, was attempted, but the patient was arrested and CPR was unsuccessful. An autopsy determined that the cause of death was diabetic ketoacidosis. Physician reviewers were critical that both the dosage of insulin and the IV rate of administration was too low to reduce ketoacidosis. Concerns were raised about poor nursing communication regarding critical lab results and changes in the patient's condition. Some questioned whether the patient aspirated when he was turned on his side for the LP, or lumbar puncture, where aspirated here basically means something might have gone into his lungs and then choked him, causing him to die even before they were able to get the proper diagnosis for the patient. So, Saj, do you think that this is more like what do you think went wrong here that was necessarily bad?
Yeah, I mean, there's many different things that you can observe here that aren't really on the right note. Like, let's take a look at the different reactions to the lab results. I mean, there were so many changes in the nurses and medical professionals that were aiding the scenario. They all didn't really have a clear plan of attack, it seemed like. And also, I mean, going into that last sentence about people questioning whether a part of the patient's reaction was really correct or not, I mean, that's a huge concern coming from an outside standpoint. And it really shows like, from an ethical perspective, it shows that they may have not necessarily been in the right place.
It's also important to mention here that with blood tests and blood cultures, typically the doctor can request for blood cultures to be specifically tested for certain things, whether it be diabetic ketoacidosis or probable sepsis. And in the case of a blood culture being tested, they can test for diabetic ketoacidosis immediately following the culture being received. So, in the case of this specific case, I think that it's important to note that there probably wasn't a great communication, kind of like how you said, great communication between the doctor and whoever was like the phlebotomist in this case. I don't know if the blood cultures would have been taken by them because, but nonetheless, because the fact that the blood cultures could have been more specifically targeted towards diabetic ketoacidosis, and then sepsis could have been ruled out already, and then they could have treated it better. The dosage of insulin and IV rate being too low is probably just poor poor management of the patient. But that's besides the fact that there was still misinformation. There wasn't not everything was given. So Saj, does that sort of make sense to you? Do you get what I'm getting at here?
Yeah, I get where you're coming from. You kind of covered a point that I did forget to cover, but I think overall we kind of covered the main takeaways of this specific scenario. Next, going into our last case of Yasanbi versus St. Louis University. Just to note that this is from the perspective from after the case. On June 14th, 2016, at about 7 p.m., a previously healthy 3-year-old child presented to the emergency room with her mother with complaints of stomach pain, multiple episodes of diarrhea, fever, and elevated vitals. She was discharged from the emergency room about 2 hours later without any diagnostic testing, where she was diagnosed with diarrhea and fever, prescribed ibuprofen, and sent home. The discharge instructions indicated that the mother should, quote, seek immediate medical care, end quote, if the child began to have blood in her stool. The symptoms did not resolve, and instead they got worse. The mom noticed blood in her 3-year-old's diarrhea and immediately made an appointment to see the primary care provider located at that same local hospital on the morning of June 16th, 2016, which is about 2 days later. Upon arrival, the patient was seen by a pediatric nurse practitioner, presenting with symptoms of blood in her stool, dried mouth, nausea, and weight loss. The nurse practitioner ordered a stool culture to test for a specific strain of E. coli that could be harmful. It carries the potential to cause kidney failure and a deadly syndrome called hemolytic uremic syndrome. Despite knowing that the 3-year-old had already been to the emergency room, that her symptoms were worsening, and that she could have a deadly strain of E. coli, they chose not to admit her for observation or treatment. Rather, they gave her mother Pedialyte, which is a child medicine for dehydration, and Tylenol, and sent them home. About 3 hours after being discharged for the second time, the mother called the office frantically. She said that her child's symptoms have worsened and now she's vomiting. She also reported that the diarrhea is still continuing. The vomit had no blood, but the mom got very worried that her daughter was getting worse and worse. And the mom also reported that her daughter was not urinating. The hospital told the mom to take her child back to the ER. So the mom and child arrived at the hospital's emergency room a little bit later, at 3:07 p.m. It was their third visit to the hospital in 48 hours, a ridiculous number. The symptoms were getting worse and worse, and the daughter was already severely dehydrated. The physician knew that this was the family's third time to the hospital. He knew that oral hydration had failed, and he knew her dehydration was getting worse. And lastly, he knew that she had test results pending that could show that she has a deadly strain of E. coli. And instead, he provided her with 20 milliliters of intravenous fluids intravenously, diagnosed her with viral gastroenteritis, and sent her home. A resident physician conducted a complete blood count, which plaintiff argued contained evidence of hemolytic process, raising the alarm for potential of a serious life-threatening condition called HUS. The plaintiff's parents were distraught. They did not know what to do. Their 3-year-old child continued to be sick, defecating blood and not eating or drinking. The child's father found his daughter lifeless on the floor of his bedroom, unconscious. He picked the daughter up into his arms, and without getting dressed, he drove his daughter back to the hospital. She was finally admitted to the hospital, now for a fourth time, and upon admission, she was diagnosed with an acute kidney injury secondary to dehydration. The test results returned later that afternoon positive for E. coli, a deadly strain specifically. During her hospital stay, the 3-year-old child developed a host of complications, including kidney failure, seizures, neurological failure, and diabetes. The injuries she sustained required her to undergo intensive rehabilitation, chronic dialysis, and a lifetime of kidney transplants and hospitalization. A previously healthy 3-year-old child is now and will permanently be an insulin-dependent diabetic with high blood pressure, kidney disease, and cognitive injury. So, Ashwin, what do you think about this specific case and the ethicality of the people and their actions within this specific scenario?
So I think the weirdest part about this case is after they sent the patient home the first time and then they came back, the nurse practitioner who saw the patient ordered a stool culture to test for a specific strain of the E. coli. And even while there was a risk of it, they decided to not observe her to not have her stay for observation or treatment. But they just gave her some Pedialyte and Tylenol and sent them home. I think the this is appalling to me in my opinion because they realized that there could have been a deadly almost deadly strain of E. coli in this child, and instead of trying to save the child, what they instead did was just to give them some medicine while they waited for the tests to keep going, and then let them go home. I feel like that was not the right choice there because they needed to keep her there for observation or treatment because they could have done something to try to sustain the patient a little longer before any of the other things that had happened where her symptoms had worsened and now the patient was vomiting, as the mom said, 3 hours after being discharged for the second time. So even something as close as that, if they had their tests ready and the test for the E. coli strain was already there, then I feel like that would have been way better for the patient. So I think in this case, just this time from when she was discharged the first time to being discharged the second time is what doesn't make any sense to me at all. I don't get why they sent her home in that case, knowing that this she had already the 3-year-old patient had already been to the emergency room and her symptoms were worsening. They decided to keep her there. I just can't understand why. Like, Saj, what do you think about this?
Yeah, I mean, you mentioned so many points of incompetency. I mean, like this just like looks bad when I'm looking at this case. I mean, it sounds bad. There's so many like I just said, there's so many points of incompetency with the care provided. I mean, she was admitted 4 times. They couldn't figure it out until then. It just makes me shake my head and wonder what's really up. And it's really it's really an ethical problem throughout the entire department, and they really should figure it out because unfortunately now the daughter or of the plaintiff or the patient has to live with this permanent disease or diseases, sorry, for the rest of her life, which sucks.
And you bring up a good point. It's not just incompetence though; it's also neglect. Because I mean, kind of like you said, they sent her home 3 or 4 times. Was it 3 or 4?
Uh, well, okay, the 4th time is when she was admitted, so
Yeah.
that last time.
So they sent her home 3 times, and in each of those times, the practitioner or wherever she went just didn't seem to care about making the patient stay to get test results back, or check in to see if there were other ways to figure out if the patient, who was again a 3-year-old daughter, to see if that patient had the strain of E. coli in her. So I feel like this really is something that they could have done better. In the case of like neglect, this is definitely not what the practitioner was supposed to do here. I feel like this just doesn't make sense.
Yeah, I 100% agree.
And I think that just about wraps it up. So that was our 4th episode. Thank you guys so much for listening to the Medicopolis podcast. We hope you all stay tuned for next week's episode and as well as what is to come in the future.